ventilation. So our objectives are to define liquid ventilation, discuss the history, describe the differences in two techniques of liquid ventilation, establish the equipment and supplies needed for use, establish when it's appropriate for use, list the advantages, and also go over the disadvantages and the adverse effects. So, what is liquid ventilation? We all know that ventilation is the use of mechanical ventilators to push oxygen and medical air into the lungs. There's another experimental option of liquid ventilation. This type of ventilation uses a special ventilator and solution to ventilate the lungs. So first, let's define what liquid ventilation is. So liquid ventilation is a technique of mechanical ventilation in which the lungs are ventilated with an oxygenated perfluorochemical liquid rather than a gas mixture of oxygen and medical air. So liquid ventilation history. Before we go into the details regarding liquid ventilation, I'd like to tell you a little bit about the history of liquid ventilation. In 1962, Callistra and colleagues first tested liquid ventilation on mice and also mammals. A liquid medium salt solution was used. It had to be able to dissolve large amounts of respiratory gases at atmospheric pressure. There was only a few that were able. Silicone oils and perfluorocarbons, which they also call them PFCs. The silicone oils became toxic, so that only left the PFCs. Next came the first human trial, which was on a 28-week-old gestational baby. Conventional ventilation was failing, so Greenspan and colleagues interrupted to allow 2 to 3 minute periods of total liquid ventilation, separated by 15 minutes. This trial was done on 3 babies, and the lung compliance improved in all 3. The babies died, but it was thought to be because of their clinical condition prior. Later, PLV, which is partial liquid ventilation, was introduced and was trialed on adults and neonates. It was concluded that PLV can be safely used in patients with severe respiratory failure and may improve their lung function. So there are 2 techniques of liquid ventilation. We just discussed the partial liquid ventilation and total liquid ventilation. So total liquid ventilation, it's extremely experimental still. No patient has ever been maintained on it. In total liquid ventilation, the lungs are both filled with ventilated with PFC using a ventilator designed specifically for delivery of liquid tidal volumes. They're filled with volume equal to the FRC, approximately 30 milliliters per kilogram, and optimal CO2 clearance is 4 to 5 breaths per minute. Early studies have shown effective. It is accomplished with a system that is similar to ECMO. The second technique is PLV, which is partial liquid ventilation. So sometimes PLV is known as PAGE, PFC associated gas exchange. It was suggested that the administration of the PFC liquid is similar to surfactant that we use in RDS. The PFC is used in combination with gas ventilation. Perfluorine distribution was given in a rotating pattern, alternating the supine and proton positioning during the incremental dosage. The dosage was 1 milliliter per kilogram. So equipment and supplies. PFC liquid are modified hydrocarbons in which the hydrogen atoms are replaced with fluorine. So this makes it an inert liquid that are non-toxic and minimally absorbed through the respiratory epithelium. The liquid absorbs oxygen up to 17 times more than saline solution and 4 times more than carbon dioxide. Perfluorine has a high density. It prevents fluid and protein from moving across the alveolar capillary membrane into the lung. Extracorporeal exchanger is used in TLV, and it is used to add oxygen and remove CO2 from the liquid. A gas exchanger, heater, and pump are necessary. PLV is easier and uses a traditional ventilator to deliver the gas tidal volumes. So equipment examples, over here on the left, we have the setup for the PLV. So it shows that you have your traditional ventilator, you have your perfluoron liquid right here, which will trickle down into the lungs. The picture on the right is an example of the pumps, heaters with a PFC tank, and how the cycle is set up, or how it would be set up with the total liquid ventilation. So you have your gas exchanger, your pumps, and your generator, and then of course your PFC tank up here at the top. So when is it okay to use? The main focus is on neonates, and limited studies have been done on humans and ARDS. Only PLV. The TLV, remember, is extremely experimental and is only used on animals. So we have the advantages. Advantages to liquid ventilation are improved oxygenation, improved lung compliance, and anti-inflammatory effect, alveolar and endobronchial lavage, and liquid ventilation with PFCs improves oxygenation because PFCs are dense and they gravitate to dependent parts of the lungs. This will in return open up collapsed regions of the lung, acting as a liquid PEEP. PLV improves lung compliance by eliminating air-liquid interface. We discussed earlier how PFC was like surfactant. The difference with the PFC liquid is that it has a constant surface tension. Therefore, the more you use and open up the atelectic alveoli with a PEEP-like effect, which that in return improves oxygenation. Studies have shown that PFC in liquid ventilation may reduce pulmonary inflammation by decreasing the cytokines production. Last is alveolar and endobronchial lavage. With using liquid, there's an automatic lavage effect when ventilating, so all of the bronchial exudates and the debris, they all come to the trachea, and then we can easily just suction them out. So, disadvantages and adverse effects. So, a pneumothorax is a common complication of liquid ventilation. If the PEEP, if insufficient PEEP is applied at the end of expiration to support the alveoli not filled with PFC liquid, the alveoli will collapse, and in return, the force can cause a pneumo. So during PLV, using conventional ventilator PEEP in addition with the fluid reduces the chances of that actually happening. Circulatory impairment was seen in TLV. This does not occur with the partial liquid ventilation. In partial liquid ventilation, there's not an issue with hemodynamic instability. Lactic acid was reported, but reasons were unclear in the studies. They did conclude that it was metabolic acidosis. And as we discussed in previous slides, with the use of the liquid, all debris and mucus can come up to the top so that we can suction them out. Well, when that happens, they can also come up to the surface and end up blocking the ET tube due to mucus plugging. So, to conclude, we learned that liquid ventilation is a technique of mechanical ventilation in which the lungs are ventilated with oxygen perfluorochemical liquid rather than a gas mixture of oxygen and air. We also went over a little bit about the history and that it was first tested on mice instead of mammals. There are two techniques. There's partial liquid ventilation and total liquid ventilation. And the only one used today is the partial lung ventilation. PLV uses traditional ventilator, and we also discuss the advantages, we discuss the disadvantages, and ultimately just remember that this is still experimental. I mean, it's not used very much, it's not used very often, and they are still doing studies on it, and I think in the future we may see a little bit more about it. All right, and on my next page is the resources and some of the information and some of the articles that I used to get the information that I have given you today. I hope everybody has a great day.